Now we will move to the third speaker in this session, Dr. Alucha from Nigeria. He's a consultant nephrologist in the internal medicine department in Asukaru District Hospital in Abuja. His main interest in interventional nephrology, and he is the chief of nephrology in the only interventional nephrology training center in Africa. Dr. Alucha will speak about the common medical complications on kidney transplants, experience from Nigeria. Please, Dr. Alucha.
Good afternoon, everyone. I want to thank the organizers for inviting me here. Okay, I want to thank the organizers for inviting me. The next 20 minutes or so that I have, I'll be sharing, talking about the common medical complications that is encountered in kidney transplant, and then we'll look at our experience in my country, Nigeria. Where I work, no disclosures. Okay, so I'll take it with this outline to introduce the topic. I'll quickly we'll rush through the classification of these complications, and then the management, and we look at our experience, and then I summarize. As everyone has said, kidney transplantation is still the most effective treatment option for patients with end-stage kidney disease, and when we're able to do that, it significantly reduces morbidity and mortality. However, it does not completely reverse the damage that is caused by prolonged kidney dysfunction, dialysis, and the use of immunosuppressive agents in the post-transplant era. And then, of course, there's an increase in the risk. So there's an increase in the risk of the complications. There's no perfect screening modality for complications worldwide, and it is essential to modify risk factors both before and after transplantation in order to reduce the incidence of cardiovascular complications post-transplantation. And either through lifestyle changes, diet, exercise, smoking cessation, or medications like statins and anti-hyperglycemic agents. Now, to classify common medical complications in kidney transplant, we looked at it non-immunologic complications and then immunologic complications. The non-immunologic complications include cardiovascular infections. The infections could be viral, bacterial, fungal, then the metabolic, post-transplant diabetes mellitus, and then, of course, malignancies. They also include things like CNI toxicity, recurrent or de novo disease, hematologic complications, and others. Now, the immunologic complications will be seen in three phases: hyperacute, acute allograft rejection, and then the chronic type, which could occur in months or years. Now, cardiovascular disease is chronic kidney disease is an independent risk factor for cardiovascular disease, as we all know, and the CVD incidence and severity usually increases as the eGFR declines. It is the most common cause of death in the post-transplant period. However, we would share our own experience as we go. Although kidney transplant is the most effective way to decrease the risk of these cardiovascular events, cardiovascular deaths still accounts for 30% of overall mortality. This is just a slide study published in the New England Journal of Medicine, which just corroborates what I've said about that the increase as the eGFR declines, the risk of cardiovascular death increases. Now, for infections, complications, it is quite common during the post-transplant period, we all know, and it accounts for about 13% of the overall mortality in kidney transplant recipients. The degree of immunosuppression and epidemiological exposures are the main determinants of this risk of infections. It can be categorized into three: early, ones we see in the first 30 days, then during the peak period between 31 and 365 days, that's a year, and then the ones that occur after a year. This is just a slide showing us all the possible infections that are quite common in the post-transplant kidney transplant patients. The nosocomial ones, quite common between the first 30 days. The ones that are donor-derived infections, and of course the recipient-derived infections. For the peak period of peak immunosuppression, during the prophylactic phase, we have all the common causes of infections. And then, of course, the ones greater than 365 days. And epidemiological exposures are the main determinants of this risk. Now, we talked about the classification, three phases: early ones, the infections during peak period, and the late onset infection. And then, of course, I think I showed this slide telling us about the various stages and the common infections that occur. The viral infections, very common. BK polyoma virus commonly occurs in the first post-transplant year, and is the most significant risk in is the degree of immunosuppression. Of course, other risk factors, donor-related risk factors, transplant-related risk factors for polyoma virus. And then Epstein-Barr virus, also very common, can manifest as asymptomatic viremia, infectious mononucleosis syndrome, or other organ involvement, such as hepatitis, myocarditis, and pancreatitis. The most concerning presentation of EVV is the post-transplant lymphoproliferative disorder. Cytomegalovirus, in the absence of preventive measures, CMV infection disease develops in about 40 to 100%, and 67% in kidney transplant recipients, respectively. Then we also have the norovirus. It's the second most common cause of diarrhea in post-transplant patients, just behind Clostridioides difficile, and causes colitis. SARS-CoV-2 virus has also been shown to be common in the post-transplant patients. These infections show the high rate of symptomatic disease, about 56.9%. However, symptoms were mild in most cases that we're seeing. Bacterial infections, urinary tract, very common. Its prevalence ranges widely from 7% to 80%. In fact, it's the most common that we see in our program. And they occur most commonly in the first year post-transplantation. The severe presentation of Clostridioides difficile will be colitis, fulminant colitis. It has also been associated with a degree of grass loss in some studies. Now, fungal infections, also quite common. Despite the fact that we give prophylaxis, we still see the various Candida species. Histoplasma capsulatum, blastomyces dermatitis, Coccidiosis imitis, and they are quite all dimorphic fungal that exist as yeast in the human body and mycelial forms in the environment. Post-transplant diabetes mellitus has been shown to be very common in our program. It's about, in the 2016 Scientific Registry of Transplant Recipients, the report, the 5-year incidence of PTDM was put about 12%. What are the risk factors for PTDM? The type of immunosuppression that is used is one. The ethnicity, obesity, hypomagnesemia, hepatitis C virus, and cytomegalovirus have been shown to increase the risk. This is just a slide showing us post-transplant diabetes mellitus, and usually associated with high BMI. The risk is high in them, and then, of course, most centers now exclude patients with high BMI for listing for transplants. Most centers will take a cutoff from 35 to 45 kilograms per meter square bit. Furthermore, a significant proportion of these patients gain weight in the post-transplant era. We know why. The high steroid dose that they take is one of the factors. Malignancies. Solid organ transplant recipients have a twofold increase of cancer compared with the general population. The incidence of infection-related malignancies are significantly elevated in kidney transplant recipients. EBV-associated lymphoma, KS, Kaposi sarcoma, hepatocellular carcinoma, genital and gastric cancers. It has been shown that, that this is a slide showing us the incidence of mortality of some non-immunologic complications that we talked about in kidney transplant recipients. 30% for cardiovascular mortality overall. Cancer is responsible for about 24%, and then infections, 13%. The hematological complications are listed here: anemia, erythrocytosis, that's post-transplant erythrocytosis, leukopenia, thrombocytopenia, thrombotic microangiopathy, and the post-transplant lymphoproliferative disorder. Now, anemia can be caused by the following: iron deficiency, erythropoietin level, EPO level, graft dysfunction, rejection rate, viral infections like CMV, parvovirus B19, and of course, the immunosuppression also will cause anemia, and of course, the use of ACE inhibitors, as we all know. I will rush through this set of slides so that we can now look at what we have as experience in our center. Medical history and clinical assessment is very important when you're evaluating these patients. You must test them for blood in the stool, CMV, and parvovirus. For post-transplant anemia, the target HB level will be 100 to 120 grams per liter, as recommended by KDIGO. HB values of greater than 130 grams per liter should not be intentionally aimed for during the ESA therapy. Post-transplant erythrocytosis, as we said earlier on, quite common. There are some factors. We look at HB of hematocrit of greater than 51% across board, whether male or female, seen in about 8 to 15% of these patients. And then the possible causes will be the native kidneys, ADPKD, male gender, repeated transplant. Excellent graft function is also one of the possible causes. The complications will include things like thromboembolic hypertension, headaches, and then of course the treatment will be to use ACEIs or ARBs. Sometimes we offer them phlebotomy. Leukopenia we also mentioned, and these are the possible causes. Thrombocytopenia we mentioned. Myelosuppressive medications including azathioprine, MMF, anti-lymphocyte antibody treatment, which we know now that over 83% of patients recipients now take one form of antibody therapy for induction. Viral infection, CMV, EBV, antiplatelet antibodies. Then, of course, diagnosis will be to do a peripheral blood film. Treatment will depend on the risk of bleeding, treatment of underlying cause, and of course, thrombopoietic growth factors are also used. Skip this. Post-transplant lymphoproliferative disorders is usually caused by EBV infection, as we all know. And then, of course, the clinical picture is an acute infectious mononucleoside-like disease, rapid enlargement of tonsils and cervical nodes, widespread infiltrative disease with multi-organ involvement. Treatment will require spontaneous regression. The common treatment will be to taper the immunosuppressive therapy, sometimes combination chemotherapy, surgical excision, and local radiation therapy. How do we manage the complications? I will rush through the treatment with renin-angiotensin-aldosterone system blockade to decrease proteinuria and hence to decrease cardiovascular risk. We commonly don't want to use ACEs or ARBs in the first 3 months post-transplant for our patients. Now, empirical blood spectrum parenteral antibiotics, which can be narrowed to definitive treatment once the organism and susceptibilities are identified. The cornerstone of management of EBV, CMV, BK viremia, and nephropathy is immunosuppression reduction, as we all know. Keep through this. Malignancies. The common cancer immunotherapy is an emerging field that requires particular attention in kidney transplant recipients. Checkpoint inhibitors, which target the programmed cell death pathway, and the cytotoxic T lymphocyte associated antigen are effective in the treatment of several types of the cancers that we see, including melanomas, renal cell carcinomas, and non-small cell lung cancers. This is just a slide showing some of the complications and the management. I will skip. We also looked at the immunological complications that we have. Plasma exchange is used, maximum of 6 sessions or until the serum creatinine is within 20 to 30% of baseline. Immunoglobulins, IVIG is used, rituximab, steroid use also. Antibody-mediated rejection. This is just a slide showing us the various second-line options that we have for management. Please. Now, chronic allograft nephropathy, the most common cause of which is the most common cause of graft failure, and is an incompletely understood clinical pathological entity, also called interstitial fibrosis and tubular atrophy. CAN is a histopathological description rather than a specific disease entity that refers to the features of chronic interstitial fibrosis and tubular atrophy within the kidney allograft. It's been given several names. I'll skip this. Now, I will want to focus more on our experience in our center. So far, we've done a total of about 783 kidney transplants since 2015. We have more males, 527 males, as against 256 female recipients. It's important to mention here that we do not have a disease donor program yet, but we are at the verge of getting legislation for disease donor program in our center. We just think that maybe we have more males because it's still self-funded, it's not under the health insurance scheme. So more men have better finances than the females. Maybe that's why we have these numbers. Infections still seem to be top on the list of the medical complications that we see in our environment. And I think it's the same for the whole of sub-Saharan Africa. However, cardiovascular complications are the most common cause of mortality. The infections, there's a study we did in 2022 that was published in Couriers, and we were able to look at the frequency of bacteria cultured in the urine in the post-transplant, kidney transplant patients. We observed that E. coli is top on the list, followed by Klebsiella, Pseudomonas, Staph aureus, and then the coliform species. Now, BK polyomavirus also we've been able to identify as a common medical complication that we have and that we see in our program. A study was published in the Annals of Medical and Health Science, how some of these patients were managed in 2021. And of course, in our recently concluded study on PTDM, the prevalence of PTDM in our center was found to be in the range of 21.64%. This is a slide of a patient who we transplanted and then eventually came down with Kaposi sarcoma. He had a lot of oral lesions. At some point, we were not sure whether it was KS or PTLD. The sarcoma lesions were located on the chest at the presentation, even internal organs, which we saw. That was published in 2023. Now, poor drug adherence is a big problem for us in our environment. The reason, because the medications are not under health insurance, and so we're still struggling with a lot of patients not being able to afford long-term immunosuppression. And ABMR was found to be a leading cause, and it was seen that the reason behind it is for poor drug adherence was first mainly from inability to afford their medications. And according to the study that was conducted in 2022, non-adherence to immunosuppressants were reported in as much as 50.7% of the post-kidney transplant patients. And I would say here that these are the ones we are seeing in the clinic. What about the ones that are not very regular in the clinic? So the study showed that 44.8% missed the timing of their immunosuppressants, 20.9% missed their doses, 11.9% went on drug holiday. Maybe they traveled and then just somehow forgot to travel with their medications. And 10.8% had their dosages altered by themselves. In conclusion, I would say infections and malignancies related to long-term immunosuppression may present diagnostic challenges in kidney transplant recipients. It is also important for clinicians taking care of these patients to be aware of the most common medical complications in the post-transplant era, and then also to have an idea of how to screen, diagnose, and treat them. As we said earlier on, there is no particular pattern. I would leave with this quote from Confucius that says, "It does not matter how slowly you go, as long as you do not stop." Thank you.
Thank you, Dr. Alucha.